Morning, everyone. Everyone can hear me good? All right. Before we get started, just kind of want to see who we have in the audience. How many are students in the audience? Okay, awesome. All right, welcome. How many are clinicians? All right, professionals. And how many are in between? All right, well, I hope that this presentation caters to you all and you're able to walk away with something that you could implement in your own practice. All right, so some objectives. Today we're going to appreciate kind of the intersection between cultural competence and humility and the application within allied health student education. I'm going to present some current literature that is associated with this within student education as well as clinical experience. Explore the cultural compatibility model as a framework for cultural competence and humility education within, and then showcase structured intervention design based on a pilot study that was done to enhance cultural humility and competence within our program at Hofstra with our athletic training students. Okay, so we'll start with identifying and defining competence and humility in allied health education. So I know that cultural competence, cultural humility has been discussed pretty heavily in the last couple of years and kind of understanding what that means. So just kind of want to give an overall definition where competence is when the providers and systems care for patients with diverse values, beliefs, behaviors, and tailors their delivery to meet patients' cultural needs. Where humility interjects with this is the lifelong process of self-reflection. So the clinician, the student, the provider is able to self-reflect on their own cultural knowledge, beliefs, and personal biases to create an environment that is safe and inclusive for all. Being sensitive to these historical realities within our knowledge and awareness helps us to kind of fight the marginalization and oppression against certain groups, but then clear the way for equity and care for all. So this is a nice construct of kind of seeing where the competence is a foundation to building upwards of our self-humility. So at the base, you'll see that developing cultural self-awareness is where it starts. We have to ask ourselves, are we aware of our own biases? Are we aware of the knowledge that we need to provide continued care? Then moving up is gaining more knowledge. So still having a foundational knowledge within our profession, but then how that relates to different groups and patient encounters that we have. Moving up to the green is understanding and readdressing power imbalances. How can I understand that what my knowledge is should not create inferiority complex when we're treating patients in a clinical setting so that we could give them equitable care. And at the very top is holding our systems accountable. So as individuals, we want to impart this humility, but it really stems from the top. Is it within our framework? Is it within our policies and procedures? Is it within our assessments that we do every day that allows us to instill this component of competence and humility? Okay, so culturally competent healthcare pretty much involves different factors. It's understanding the cultural differences that impact patient health outcomes and experiences, considering religion, gender identity, socioeconomic status, race, identity, et cetera, whatever that affects the patients, considering those factors when we give patient care. Applying our knowledge and sensitivity within our practice with each and every person that we meet, assessing healthcare providers and the systems that we work for to know that we are enhancing the best outcomes for our patients, demonstrating these skills through culturally sensitive assessments and plan of care, and then developing a self-awareness of these biases each and every time we approach our patient care. Okay. So to improve healthcare, knowledge and experience with cultural competency enhances the quality of patient care overall. The lack of knowledge and experience is decreased with these quality of patient cares. So we're gonna have a little interactive component today, so make sure you guys are awake. So if everybody wants to take out your phones, you may. You could scan the QR code, it's gonna link you to a Mentimeter, okay? All right, and then we will switch to our live Menti poll. Perfect. So the question is, in one word, what does cultural humility mean to you in a clinical education or patient care? If you missed the QR, you could enter the code if you could type in menti.com. Okay, so some of the terms coming in is respect, respect with emphasis, I love that. Empathy, understanding, quality, humble, compassion, equality, awareness, sensitivity, yes. All right, good. So this kind of provides a real-time kind of understanding of it, whether you are well familiar with it, whether you've already practiced this, or just kind of learning this new, you're understanding that there is a need for all of these components, right? When we're treating our patients, or as we're learning how to be better clinicians, right, from a student standpoint. And these are all things that need to be included when we're teaching, when we're assessing, and actively in our clinical practice. Open-minded, adaptability, diversity, listening, yes, for sure. All right, great. Thank you so much for that. All right, so we'll switch back to the main presentation. Wonderful. Okay. So now we're going to review the literature and kind of what it says about cultural competence in allied health student education. Okay. So what does it say? So our preceptors, our clinical supervisors, and students definitely recognize the value of cultural competence education, which is great. Demonstrate good cultural awareness and sensitivity, so that self-reflection of where we're at and what we want to provide is definitely evident across the board. Confidence in cultural competence and knowledge gleaned from formal education is definitely rooted in what instructors and professors are able to provide in demonstrating this knowledge. But there is a lack of confidence, right, translating that knowledge into effective healthcare skills and behaviors. So the research says that we're aware of it, we want to do it, we want the opportunity to do it, but if something kind of trails off or is lost in translation, that is not either kept up or the availability of performing these skills with diverse populations doesn't carry through from either their education to their professional setting or even throughout a professional's career. Okay. So recognizing that there is a knowledge to practice gap, short-term cultural competence education experiences do not work. So kind of the one and done trainings or one and done workshops that are probably done within an academic career or even as a professional within your institution fail to develop this sustained learning and practice. They don't translate to knowledge to patient care because something is always missed. It's a continual learning that needs to be provided. Another gap is the lack of diverse patient encounters. So that limits the behavior of modeling and mentorship for the instructor or the clinician working with students and students themselves. This reduces opportunity for student skills and behavior to be practiced throughout, and then restricts new knowledge, discovery, and application of providing culturally competent care, and hinders the self-reflection action as well too, which is the stem of culturally competent and humility as well too. Okay. So what are some things that we could do or the research suggests? It's a responsibility of our allied health education programs to help bridge this gap the best way that they see fit within their curriculum. So cultural competence and humility, education and patient care experiences need to be purposeful, ongoing, and sequential. Like I said, the one and done does not work. A lot of studies show, even with pre and post surveys, that there is a lack of continued knowledge, skills, and behaviors, even despite learning and increasing self-awareness initially. It drops off. So it has to be ongoing, sequential, and there's different things that we can do to provide that for our students and our young professionals. Students want more information, right? So they're already getting all this information on competencies and assessment and skills and testing, but they also want more information on how that could be applied to many different diverse groups. More practice being able to do it. So just like we're able to practice our assessments, our testing, how can we do that so that they're able to practice it within this culturally competent landscape so that they feel more confident going into the world providing that care. Students want different clinical education experiences, so clinical immersions and internships can provide that opportunity, as well as be able to have diverse patient encounters that are sequential upon each other so they continue that self-reflection. Okay. Students need mentorship, right? So it kind of stems from within the program that they're in, professors, clinical coordinators, instructors, even into as they become young professionals, need a mentor from maybe a senior professional to guide them and support them in their need of wanting to provide culturally competent care. So the way that we model that to them and kind of create that environment allows them to then explore that themselves. Okay. So modeling those behaviors definitely improves learning outcomes for the students, and as the students are learning and building their own self-confidence, results in patient outcomes as well too. So modeling competence and skills and humility and behaviors really does help with that, and it stems from the knowledge and awareness that the professors, instructors, or professionals can provide to our students. There we go, okay. All right, so this is just a diagram kind of showcasing the ongoing process, right? So we talk about the education component needs to be ongoing in all the settings that our students are in, or even our young professionals, having the opportunity to practice, creating that knowledge and opportunity for them to model those behaviors. And then there has to be an assessment and self-reflection. So the assessment can come from an assignment or a task or creating a competency-based skills assessment, but then there should be a portion where the student is able to self-reflect on that experience to showcase that there is improved gain of learning and skills and behavior. Okay. So within didactic education, we want to seek resources, right, that expose or are able to enhance cultural competence and humility through knowledge and skills to better serve diverse populations. So these are things that as educators we could impart and deliver in any content that we're teaching. Just different classroom methods that apply patient case scenarios, self or group reflections, question and answers, just creating an open dialogue and a safe space for people to ask the challenging questions and even to admit when maybe we're wrong or we don't know something, which then showcases that behavior to seek the right information through presentations and representations of those different backgrounds and clients that we may see. Simulated skill instruction to be able to deliver the information through workshops, role play scenarios, simulated case scenarios, or even standardized patients if that's available within the program. Okay. Within a clinical setting, all right, we look to preceptor or clinical supervisor mentorship. So the mentors should be from diverse backgrounds, not only as they identify within their culture, but maybe also from their profession, having a varied view of how they approach centered care with diverse populations is important. Skill and behavior developing, we want to also train our preceptors or train our clinical supervisors in what we're looking for in our students so that they could replicate that themselves. So it's important to train and have all stakeholders on board with what we're looking for, so that this way when students are graduated, it's self-reflected in the professional setting that they're going to want to be in as well too. So the professors and the clinical instructors should also be trained and understand what that means through different patient encounters, role playing, and training, ongoing training. And then student assessment, right? Train our preceptors to identify and assess these behaviors in our students through student level appropriate assessments, so that this way there's an objective measure that could be discussed to better improve how the student performs, as well as within a workplace when we do employee reviews, there should be something there that shows holistically how they're approaching inclusive care. Okay. And then within our clinical experiences, we want to ensure that the sites are committed, right, to cultivating an inclusive and welcoming environment that values diversity. So kind of at the top of that pyramid I showcased before, it starts with our institutions and organizations creating that environment for us to work within it. Engagement is also key, engaging the students on ongoing examination of these processes, policies, and practice to make sure that we're eliminating barriers to equitable care. And then the patient encounters are always important. Having documentation of diverse patient encounters and capture student reflections when they do have these encounters to self-reflect if they ever have a circumstance in the future with that, how they were able to treat it, and maybe some differences that they would do to make sure that they are self-reflecting at each and every encounter. Okay. So now I'm going to discuss the term cultural compatibility as a framework for ongoing cultural competence education. So Dr. Kambina Bacote is known for the 5 constructs of cultural competency, which is something that you might have heard of. So the constructs are awareness, skill, knowledge, encounters, and desire. But compatibility combines the competence and humility component, where humility is infused at the center on how we explore these constructs. So humility is at the center, and then from there we're able to self-reflect on our awareness, skill, knowledge, desire, and encounters with patient care. Okay, so this is coming from Dr. Kambina Bacote, where she asks the question, have I asked myself the right questions? So this represents the self-reflection component and humility that we should be able to kind of go through holistically before we approach patient-centered care. Okay, so some examples of what this would look like. Am I aware of prejudices, biases, as well as presence of racism or other isms, so either discrimination and other things that ward and create a barrier in patient knowledge? Do I know how to create a culturally specific history, physical, mental, medicine, medication, or spiritual assessment in a culturally sensitive matter that would be able to best serve our patients? Do I have knowledge regarding different cultural views, the field of biocultural ecology, importance of addressing social determinants of health, so kind of understanding what the foundation is for that specific person and learning from the patient, letting them tell you their story versus assuming on what we have on our own professional knowledge. Do I have sacred or unremitting encounters from people with different cultures than mine? And am I committed to kind of resolve any conflicts that we may have, whether it's a language barrier, health literacy barrier, or maybe gender barrier as well too? And then the last one is, I think, is super important. Do I really want to engage, right, into this process? You don't have to engage if you don't want to, but you really want to, and that inner desire needs to come from within, and then that's where the humility will be exposed with each and every encounter that you have. So within student learning, we could take each of these constructs and embed it into your program. It's pretty easy, it's pretty seamless, just kind of creating those self-reflection standpoints so that they're able to address any biases or misconceptions about maybe the assessment or the diverse cultural background that the patient might be from, and kind of developing an openness to create a safe space for them to explore that. Knowledge is definitely embedded in a lot of our allied health education, where we're exploring different concerns for different groups of people, but it should just be a foundational knowledge and not created as an assumption when we're creating our patient encounters. It should be something that we could come to the table with, but let the patient educate us on what we know and we can meet in the middle. Practical skills goes back to kind of those clinical experiences with our preceptors or instructors, allowing them to conduct these culturally sensitive assessments or adapting as we need to in real time, and always communicating with kindness, which was a lot of what you guys had put in the word cloud earlier, right? So listening, empathy, understanding, that's a practice, right, that we need to continue to do no matter where we're at in our profession. Okay, so exponential learning as well too within this framework is key. Engaging with diverse individuals, and doesn't necessarily have to be diverse culturally. Like I said before, it could be a diverse medical condition that maybe is not as common, right, in your field, but learning about it, being open to it, and be able to kind of learn from it, so if ever in the future you have something to rely back on, and that's sustainable as well too. Motivation, being able to foster the desire to learn about diversity is super important, and moving from the have to the want to, right? And then commitment to social justice and humility is part of this framework, and just practicing humility by addressing inequalities, trying to eliminate those barriers in health equity, and then advocating for those that may need a voice to be able to access healthcare and access the care that you could provide in an easy way in a safe space as well too. Okay, so I'm gonna kind of tap into a little research that I've been doing at Hofstra, along with special shout out to Dr. Ellinger. So we try to address these gaps in the literature within a pilot study within our program by creating a multi-step intervention approach. Okay, so within our academic standards and many of the academic standards that are represented today, right, it's stated and required that cultural competence and humility has to be part of the student's education. So we need to be able to deliver it, practice it, implement it, assess it. And a lot of times I feel that instructors may kind of get stuck on how exactly we implement it. Do we do a one and done within a module? Do we create a whole course? How does that look like throughout a curriculum? And there's different ways that you could definitely approach it through a didactic or clinical standpoint. So our study looked on ongoing and progressive learning opportunities to be able to apply these practical applications within the framework, and sustained learning for our students to see that it is carried out throughout their practice. Okay. So we used the framework, which was aligned with our accreditation standards, applied a structured multi-step intervention design, integrating instructional methods, as mentioned before, to promote all the things that allows us to use this framework as the basis of our pilot study. Okay. So this is a little bit of our design that we did. So we did 3 interventions over the course of the school year. So we did one August 2024, December 2024, and then March of 2025. And we did a intervention at first with foundational knowledge, so kind of working on the knowledge standpoint, kind of setting everybody at level 0. Then we presented critical thinking, case reviews, as well as self-reflection and discussion. So we had feedback individually and as a group, as a cohort. And then we just did a post-survey to see how much they were able to gain after the first. Once we got the results of that, we addressed those gaps and then created an intervention the second time, which worked on acknowledging and advancing those knowledge that was gapped from the first intervention. Then we focused on physical examination and case application, which is one of our domains as well. It relies on the skills and behaviors within the framework, reflections, case studies, and discussions. And then we also did a post-survey. Based off of the qualitative and quantitative results, we were able to then impart a third one where we advanced that knowledge and reflection. Then we focused on student design role play, so creating case scenarios and have them acted out in real time, so they're having the experience of being that diverse patient. And then we had one being an observer. So we kind of, the investigators, we took ourselves out and let the students run the simulation themselves, and then they provided us with feedback and then a survey afterwards. Okay. For our quantitative data, we did use the inventory for assessing and processing cultural compatibility. This survey is pretty new. Dr. Kabina Bacote came up with this in 2020, as compared to her previous version of this, which includes the humility. So it's based on the different constructs of the framework, and then the scoring is a 4-point scale. So culturally proficient is 4, or on the higher end of the range. 3 is culturally competent, 2 is culturally aware, and 1 would be culturally incompetent. Our qualitative data, we assessed post-intervention 2, as well as on the third intervention, kind of just asking open-ended questions on what they experienced, what could have been enhanced, so that this way we made improvements for their ongoing clinical learning and didactic learning within the program outside of the interventions as well too. Okay, so this is the result of our survey. So orange is the first intervention, blue in the middle is the second, green is third. So across the board, there was improvement. Humility was the highest. Second would be awareness and desire. And then with skill and knowledge and encounters, that kind of fluctuated, which was kind of to be expected based on the literature, knowing that if ongoing sequential skills and encounters were not kept up, there would be a little bit of a slope down or a plateau in these areas. But overall, we were pretty satisfied with the results just based on the 3 interventions we were able to do. Okay, so this is just kind of overview of the results. Awareness, there was no real significant change, but the awareness and biases of stereotypes increased significantly through the interventions. With skill, there was a significant change for role of cultural assessments in preventing misdiagnosis. So we think that our intervention on the second one improved everything. Knowledge, there was minor improvements, but there was a little bit of a slope down. Encounters slightly increased, but it was still limited by cultural, clinical exposures to diverse populations. And then desire and humility still kept up with each exponential intervention. So the student insights on the training definitely enhanced their knowledge, increased their awareness, but due to limitations with the study and limited real-life exposure, immersion, and opportunities for practicing application, those were the areas that were identified as barriers to really kind of be successful in creating these interventions. So you can take your phones out again, or if you're still on the same Mentee screen, you could QR code that, and then I will pull up the Mentee. Perfect. All right, so if you don't mind, which factor most influences the development of cultural humility in future clinicians based on what you've learned today or your own thoughts? Okay, so we have diverse patient encounters in the lead, reflection of self-awareness, ongoing feedback and assessment, faculty preceptor modeling, okay, and then evidence-based teaching and research. So definitely diverse patient encounters is key, right? We talk about it, we understand it, we want to practice this, right? Being in this profession, we want to be able to display our skills and really make a change in our patients' experiences, right, with healthcare, so that this way they're understanding that they can come to you for anything that is bothering them without fear or judgment. Reflection, right, so that's the humility standpoint. We definitely understand that's super important. And then feedback, right? We want to know that we're doing a good job, whether it's from our preceptors, instructors, or our supervisor in our professional settings. So this is good. All right, good. I appreciate that. Thank you guys so much. We'll go back to the presentation. So some key findings from our studies show that there was significant growth in humility and desire. They scored high with humility and desire initially, and that was sustained through, which was good and showed that they are aware of kind of their own personal biases, and they've been challenged and self-reflecting even as they continued in their clinical experiences. There was gains in awareness and knowledge because of the information that we presented to them, especially with physical assessment. And in the third intervention, we also focused on holistic and spiritual medicine and pharmacology so that we could combine cultural beliefs and behaviors with traditional medicine here. So that was definitely gained throughout the interventions as well, too. There was limited change in skill and encounters, as I mentioned before, suggesting that students understood the constructs, but actual application was limited, which supports the literature and the gaps that we saw before. The qualitative feedback confirmed this, so it aligned with that literature and allowed us to then adapt our future interventions as well as within our coursework, how we could adapt those experiences for them within the clinical setting or through simulated cases in the clinic. And then the qualitative reinforcement to the quantitative trends as a mixed method pilot study definitely emphasized kind of the combination of both and what we need to do from a data standpoint to drive these interventions within our program ourselves and how that could be reproduced throughout educational programs throughout our allied health professions as well, too. Okay, so some implications on how this could be put into practice. We want to integrate the humility as the core of our learning outcomes. Competence is not just it, it's the humility, and it has to be ongoing. So embedding these through self-reflection, journaling, peer dialogue within a didactic or clinical course reinforces that lifelong learning and self-evaluation that the students could carry through into their professional careers. Adapt a layered approach to the instruction. So kind of a lot of the stuff that we did, even though it was within a specific, time that we had outside of the classroom, these are things that could be adapted within the program, within the curriculum, so that it's sustained and we have objective measures to provide that feedback within our approach as well too. Increase real-world cross-cultural encounters, right? This is what we need, this is what the students wanted, this is what the literature exposed, this is what our pilot study also exposed. So fostering that interprofessional or even community outreach partnership to provide those diverse real-world care experiences that strengthen cultural dialogue across disciplines as well too. Okay. Sustained reinforcement beyond the one-time interventions, so integrating these milestones longitudinally throughout the coursework through didactic simulation and clinical phases will help the students then embrace this type of inclusive care, prioritize reflection and feedback. So the students are only going to do what they think they're able to do and what they think they're doing right, but without proper feedback in any competency, they need to know what they could improve on and continue to improve on. And this is definitely a skill that needs to be improved on. It's not just like, okay, they've done it, they're good, that's it. No, we need to reinforce the fact that they need to continue the good work that they're doing. And if there's anything that comes up that challenges them, be okay with not knowing and be okay to research it or lean back on their mentorship to provide them the support that they need to be allied health professional. And then modeling in the faculty and preceptor, we need to be also educated and continue to learn and be in a space to continue to learn and provide ethical practice within our settings so that this way it's seen, it's applauded, and it's also being honored, right, through our students and young professionals as well too. Okay, so in closing, bridging the gap between research, knowledge, and clinical application begins with us. When competence and humility are grounded in evidence within the framework that we discussed, we move forward from the actual intention to actual measurable impact. Cultural compatibility is the ongoing journey of inquiry, reflection, and connection that transforms both education and patient care. Yeah, thank you. I appreciate it.